This is Chapter 16, Health Problems of School-Age and Adolescent Children. Problems with elimination, one is enuresis, which is bedwetting. This is more common in boys, and will resolve usually by 6 to 8 years of age. The families say these kids tend to be really sound sleepers, so they don't wake up with the sense of needing to void. We also know there's a real family tendency here. The parents were likely to have also had problems with bedwetting past the age where other children were potty trained at night. So some of the treatments, restricting fluid in the evening, so nothing to drink after dinner, and no sugary or caffeinated beverages past 4 p.m. A lot of parents will try interruption of sleep, so they wake the child up and have them void during the night. And then there are a number of bed alarms that you can buy that as soon as there's any moisture, as soon as the child starts to void during the night, it alarms and wakes them up. And so the hope is they kind of become conditioned that they start to feel that sense of I'm about to void and wake up and can rush to the bathroom. If nothing else works, there are medications that they can use to either produce less urine at night, that's the DDAVP, or have the bladder less likely to void during the night. Another problem of elimination is encapresis, and this is passing of stool. The definition is repeated voluntary or involuntary passage of normal feces into inappropriate places. So this is a child who should be potty trained. They're old enough, but they're having stooling, not into the toilet, and they're not on laxatives. There is no medical problem causing this. This is more common in boys. It's often triggered by stress, and sometimes that's fear of using public restrooms, fear of using the bathroom at school. And so what happens is they'll hold the stool. Because they hold it, they become constipated. The stool gets larger and harder. And then when they finally do go, it's very painful. So that reinforces this holding the stool. They don't want to go because it's going to be painful. And because they held it so long, it got big and hard, and it is painful. And over time, that kind of destroys the sensation of needing to go. So then they start not having good control of their bowels. So our goal is to get these kids bowel control. Most children will have 1 or 2 soft formed stools a day, and that's what we want to get to. So we need to figure out what's going on. Is it a fear of using the bathroom at school? Is it dietary? What's causing this? And dietary interventions may be enough. Increase their fluids, increase their fruits and vegetables. If that's not, then we can try stool softeners, because often the most common thing causing this is this constipation and then painful stooling, which triggers more withholding and more constipation. And then figure out what psychologically is going on. Are they afraid of the school bathroom? What's going on? And then try and intervene with that. Attention deficit hyperactivity disorder. This is characterized by 3 components: inattention, impulsivity, and hyperactivity. Inattention, I think it's makes more sense if we think of it as distractibility. It's not so much that they can't attend, it's that they attend to everything. So instead of just looking at the book they're supposed to be reading in class, they're listening to the sound that the air conditioner makes, and they're looking at the pencils laying on the teacher's desk, and the kid next door at the desk next to me has new blue shoes, and that girl's shirt is a funny color, and they're seeing everything. So they're distractible. They're not attending to the one thing they should be attending to. And then they're very impulsive. It's recess, so they get up and run and out the door and push everyone out of the way. And if you ask them why they did it, they'll say they don't know. They really act before thinking, and that can have social consequences. The other kids don't like it because they tend to cut in line and push, and they don't have good impulse control, and that causes social issues. And then hyperactivity. All of these can have varying degrees, but I think hyperactivity has the most variation. Particularly girls often have minimal hyperactivity that shows, where a lot of the boys, they just really truly can't sit still. And so teachers notice that, where they may overlook the girl who doesn't have nearly as much hyperactivity. So these behaviors have to occur in at least 2 settings. That's usually home and school, and they have to interfere with normal functioning. So the best treatment is multimodal, to try more than one thing. Behavioral therapy, making a behavioral chart or contract with these kids. So you will do this. If you do this, these are the rewards you'll get. If you don't do this, or you do this instead, these are the consequences that will happen. So making those contracts and following through with them. Medications, the medications we use stimulate the brain to allow it to attend, to get rid of that distractibility, so they're able to be more attentive. The medications actually are quite close to caffeine, and like caffeine, the side effects tend to be the same problems, that they tend to decrease their appetite and interfere with sleep. So we usually want to have these kids eat breakfast before they take their medicine. And some of them need the shorter acting, because the long acting's nice because they don't have to take it again to do their homework in the afternoon, but the long acting may interfere with them being able to sleep well. Family education and counseling. Family needs to learn how to make these behavioral contracts with the kids and how to follow through on them. And then classroom and home environment, making it so that there aren't as many distractions. Finding a quiet place where the child can do their homework. Okay. Acne is a problem most teenagers go through. And it happens because the sebaceous glands become very active. So we get a lot more oil produced. That oil picks up dead skin and dust and dirt and then plugs the pores, and then the acne germs get a chance to get in there and multiply and infect. Our peak age for girls is 16 to 17. Our peak age for boys is 17 to 18. Some of the things that contribute to it is a family tendency. If the parents had issues with acne, the children are more likely to. Hormones. Girls have more flare-ups right before their period. The hormonal changes premenstrually can trigger flare-ups. Stress will contribute to it. Cosmetics plug up those pores and then cause the acne, and so girls use more cosmetics that just then cause more acne. Food does contribute to it, but the studies say it's not as all that clear-cut, but dairy and high sugar foods are the ones that seem to be the biggest culprits. Treatment. Anything that improves the child's overall health will improve acne. So getting enough rest and exercise, eating a balanced diet, decreasing stress is going to help. Cleansing, but not over cleansing the skin. Just once or twice a day with a mild cleanser. Kids who have a lot of acne on their forehead or around the hairline, shampooing regularly and a hairstyle that pulls the hair away from the face will help. We have a lot of medications for acne. These first couple are over the counter. Retin-A, it's a cream or a gel, but it does make them prone to sunburn. So we want to let them know they need to use a sunscreen. There's creams and gels out there with benzoyl peroxide in it, and it works, but it will bleach their sheets and their clothes. So we need to let them know that, but they don't have to worry about it bleaching the skin. Then prescription things, topical antibiotics that they apply on the face will help. The topical antibiotic works best when combined with a benzoyl peroxide cream. The two together work better than either one alone. If nothing has worked, then we may go to a systemic antibiotic. So we have a child take a low-dose oral antibiotic. But like any antibiotic, we need to have them watch for GI upset and diarrhea. Most of the ones we're using cause photosensitivity, so use that sunscreen. And vaginal yeast infections are always a risk with antibiotics. They do, with that hormonal component, that combining the oral antibiotic with birth control pills often will be effective for some girls. We have a medication out there, Accutane, that is extremely effective for the cystic type of acne, which are the big red sore ones. The treatment lasts 20 weeks. It's highly effective, but it also has multiple side effects. It will dry the skin, give headaches, but it can cause mood changes, including depression, and including suicidal thoughts. So we need to be watching kids who take it. It's also highly teratogenic. So if a girl is taking this, we want to make sure she's also using birth control, because it will cause anomalies to a fetus. Obesity. We see a lot of obesity nowadays in kids because they're just not as active. So it's defined as at the 95th percentile for age and gender and height. So this is not just the really tall kid. This is the kid who, at their height, they weigh they weigh more than 95% of other kids their age and height. And overweight would be there at the 90th percentile. We've got 25 to 30% of our children obese nowadays. And one of the problems is there is a genetic tendency, and it affects their metabolism, but also the eating behaviors that they learn. And then they become obese infants, they become obese children, they feel guilty, they can't run around as easily as other kids, so then they kind of isolate themselves and eat to feel better, but it contributes to the problem. And with that, we see type 2 diabetes in kids now, which we didn't used to. Obese kids tend to be obese adults. We get all the, hypertension, hyperlipids, cardiovascular disease that we saw before, and that social isolation where they feel bad and then they eat, and then that just contributes to it more. So getting them to diet and exercise is really what we want them to do. They need to be out there with the other kids, get in a group where they can play and run around. And we don't use the sort of therapies we use with adults, though. Rarely will they use any pharmacologic, so diet pills, we don't do those, and we absolutely don't do surgery. When a child's still needing to grow, those weight loss surgeries are hazardous. School phobia. There are kids who have basically a panic attack at the thought of going to school, and this is real. It's not just that they don't want to go. It's a true psychological reaction, and so we need to figure out what's going on and try and treat that. The longer they stay home, though, isn't helpful. That's just going to be worse when we finally do try and get them back to school. Things that are not on the exam, all the reproductive stuff, that was OB, and eating disorders, substance abuse, and suicide will be on your psych exams. So that is it.